Good morning, everyone. And, I'm extremely excited and happy to introduce this morning our really very VIP speaker, Dr. Besselink from the Netherlands. Dr. Besselink, besides to be young, and, normally we don't say the age, but I think in this case is important. He's 47. He's a very accomplished person, and you will see by his presentation. He is currently professor of pancreatic and hepatobiliary surgery at Amsterdam M.Sc. He studied at Utrecht University Medicine and at Oxford University Evidence-Based Healthcare. He's the co-founder of the Dutch Pancreatitis Study Group, and in 2012, he co-founded also the Dutch Pancreatic Cancer Group. In 2016, the European Consortium of Minimally Invasive Pancreatic Surgery, and finally, in 2019, the Global Audit of Pancreatic Surgery. Marc has more than 800 peer-reviewed published papers, and he has coordinated over 20 prospective randomized trials. So I think really this is something really difficult to compare with anyone else. He's currently the chair of the scientific committee of the Dutch Pancreatic Cancer Group, and this year has been elected president of EHPBA. So I really welcome you, Marc, here, and thank you for coming to Denver.
Thank you, Marco. Morning, ladies and gentlemen. First of all, thank you for the invitation to come over here. Beautiful for the great sushi last night. So I'm going to speak about pancreas, but I'm mostly going to speak about a model of doing collaborative research, and I hope it's interesting for some of you, and hopefully all of you. And I'm looking forward to the discussion in the end. So of course I have some disclosures. So basically all the companies gave some money, so we're neutral there, and then some government organizations. So this is a few years back, but Sir Richard Horton in Lancet said, and this goes for all of surgery, surgical research or comic opera, questions but few answers. So apparently the rest of the medical world doesn't think too highly of surgical research. So we just this year published this systematic review in BGS looking at surgical randomized trials, so which could be anything from cardiothoracic to vascular to trauma to orthopedics, general surgery. And a surgical trial was defined as the first or last author being from a surgical department. And we looked at 3 individual years in PubMed, and then looked at the absolute and the relative volume of trials and the quality of the trials, and we compared countries. So you see here, 99, USA was leading, and now last year it was China, and you see the Netherlands there, number 4 in the world on absolute volume of trials. But of course, we needed to come up with a trick to get ourselves higher on the list, which is divided by the number of inhabitants, so the relative volume of trials, so the number of trials per 10 million inhabitants, and yeah, you see the Netherlands just runner-up after Finland. And then for the methodological quality, UK is leading and Netherlands is number 2, and you see there USA number 7. So we're doing pretty good as a country. So the question is why? Why on earth would the Dutch have anything in favor of other countries? What are the reasons behind that, apart from the just great group of friends and tiny country, 18 million people, 18. Well, there's some factors. So medical factors are that we have a very strong collaboration between centers because we need to collaborate. We are stuck between the UK and Germany. So if you don't collaborate, you're nowhere. And we have a system where PhD students right after medical school can do a PhD in 3 years. If they do that well, they can get into surgical training. If they don't do that well, they go to become a JP or radiologist or I don't know what. So it's important to do a good job. And all of us love evidence-based medicine and randomized trials. Next up is we don't have a pay-per-procedure system. So if I do 1 Whipple a year or 500, I get the same amount of salary. And for the same for the endoscopists. So you can compare endoscopy versus surgery. You can do all those trials. Patients are referred to a unit, not to a specific surgeon for his or her skills. And we have nationwide registries, which are mandatory, which you can then use to do clinical studies. But we also have some very specific cultural factors. And well, sorry that the picture doesn't show up, but we have the necessity to collaborate in our DNA. And the picture that used to be here is that 85% of our population lives below sea level. So where I live, Amsterdam, is 4 meters below sea level. So if we don't collaborate and maintain our dikes, we will all die. So it's a very strong incentive to collaborate. And then the Dutch word for that is polderen, but it probably translates to consensus building. And because of that, we're huge fans of efficient working. You can see any Dutch person going anywhere, they're always complaining about some handle or some doorway or some procedure that could be done more efficient. And we very direct, the British think way too direct in our communication style. So just to show you one example in pancreatitis, and then I'll move on to pancreatic cancer. As a medical student, I was involved in setting up this group. So something's going wrong with the photos, but anyway, this is full of logos, and basically all the centers in the country are collaborating in this group. And for this one, it did come through. So the first 10 trials that we published as a group, all of them are published in Lancet, New England, and JAMA. And the interesting thing is, of these 10, only 2 were positive, right? So 8 of them, we failed to demonstrate our hypothesis. So why are they in big journals? Because we just took on a question that came from everyday ward rounds. So just a very practical question, ERCP, yes or no, antibiotics, yes or no, show the common things. So if the trial is negative, it's still clinically relevant. But we got a few more ongoing. There are 10 more in the pipeline. The top is 5 randomized trials, and then a few more non-randomized trials ongoing at the moment. So then we try to replicate that for pancreatic cancer. It becomes, of course, a bit more difficult. You get med-onc, radiotherapy, you get a whole larger group of medical specialists involved. But essentially, we largely succeeded in that. Because these are the first 10 randomized trials we got completed with this group. So you see that so far we failed to get into New England, but who knows, we will. And the bottom 4 trials have been completed and have now submitted or also almost submitted. And I want to point out, because you will see this more often, these flags, that as of recently, we're also starting to move into Europe, because clearly when outcomes get better, you need to dig into subgroups for trials. And then our tiny country of the Netherlands is becoming too small for that. And then we got 29 more multi-center trials in the pipeline or actually ongoing. These are randomized trials, and these will start next year. And then we've got 23 non-randomized trials. And this one, Marco Docchiaro Professor Docchiaro is operating involved closely, and I'll show you a few slides just after this. So just a very simple trial we did. We completed the world's first trial on neoadjuvant treatment in pancreatic cancer. Clearly has been shown in almost any other cancer. Has been tried in pancreatic cancer, but all the trials failed to recruit, so stopped early, or had negative or very positive results that they stopped early. So this one was completed. Very simple trial design, surgery followed by gemcitabine or gemcitabine-based radiotherapy, surgery and more gem. And of course, gem and not FOLFIRINOX. This trial was designed 15 years ago. So neoadjuvant did better, still poor, but 3 times better 5-year survival than upfront surgery. So then, of course, we came into the era of FOLFIRINOX. So we did the PREOPANC 2 trial, basically the winning arm of the PREOPANC 1, and then FOLFIRINOX chemotherapy before surgery, no surgery, and then nothing adjuvant. Clearly, FOLFIRINOX, the newer, the better chemo. So interestingly, though, this trial finished ahead of schedule. So it went really, really well. And the nice thing about the Netherlands is you can actually tell a patient that if they want neoadjuvant treatment, the only way to get it is to participate in the trial. So that helps with the inclusion. So then here's a good friend, Professor Katz, saying, I bet my house that FOLFIRINOX will be superior. Marco, you were there in Pisa when we had the world consensus. And we did a little poll on now called X. So my co-worker from Rotterdam, Bastard Koekam, said, what do you think who will win? 63% thought FOLFIRINOX, 11 gem, and 26 thought there was no difference. And the good news is, first, before I show the final result, so this is the treatment. And you see actually that the gem-based radiotherapy, more patients complete the treatment than FOLFIRINOX because it's less toxic. But the good news is that I won a house because no difference. So no difference between gem-based radiotherapy versus FOLFIRINOX in this randomized trial. There's actually some benefits for gem. So you see a significantly higher N0 rate. So this p-value is over this entire difference. And there's more toxicity with FOLFIRINOX. And then febrile neutropenia. So this is very interesting. So you can now use this regime for your patients who are probably not fit enough for FOLFIRINOX, which before this trial, no one would even have predicted, as you saw. So now the final question for pancreas is clearly resectable, upfront resectable. And we're doing in the PREOPANC3 trials of FOLFIRINOX 8+4 versus 0+12. And here also 3 centers throughout Europe are joining us. So throughout this presentation, I'll have a few of these sort of tips and tricks slides. This is the first one. So the lesson we learned is basically it all starts with a collaborative group. And there's a few very simple things here. So a website, a team logo. For instance, for our groups, we decided that you never can use your hospital logo. So I'm not so good at US sports, but better at soccer. Say you would not show Ajax and Feyenoord, which are Dutch soccer clubs, but you only show the orange national team. So you would always be Team USA. All right. So in your PowerPoint slides, you would only show the slide of Team USA and not of Anschutz or whatever. And that then creates the group feeling, and that then prevents distrust and people saying, well, he is showing off with also my results. It's very, very strong psychology. It's very, very important. So it needs to be a democracy, not an autocracy. And then if you have a trial design, get together with friends from several centers, take your time. Every trial has multiple PIs, so it shouldn't be the one man or the one woman show. Multiple PIs who share, who discuss a lot. It takes more time, but in the end, you'll have a better study and a better accrual. So have a lot of meetings, take your time with 10 to 20 people, listen to people, adapt the protocol, bring the protocol back, take your time in developing it. And then really it's all about cherishing and building that we feeling. It takes a lot of time, but you'll double back on that in faster accrual rate. Okay, so it doesn't have to be only randomized trials. What you can do is use this approach to get a new approach implemented in your hospital, in your network, in your state, in your country. So if we did this, for instance, with minimally invasive distal pancreatectomy, this very simple, basic, simple operation before 2005 was not done in the Netherlands. Even before 2013 was almost not done. It was a 38% conversion rate. So we said, okay, we do a nationwide training program. We'll take care of everything for you as a hospital. The only thing we want back that immediately after we trained you, we want you to join the randomized trial. It's a pretty good deal. So we had, because of the training program, a 700% increase in the procedure. Conversion rate went down from 38 to 8%. And mortality 0. So this is on a nationwide scale. So immediately thereafter, we did the randomized trial. In all these trials, we blind the patients, which is good fun, because at day 5, there's like a big de-blinding ceremony. Families there taking photos, and typically 50% think they had the opposite procedure. So you do actually make it more difficult on yourself to show a difference there. And this was the outcome of the trial. It was a lot better than we expected, because this is the composite of all these components. But actually, each of these components was significantly better for MIS than open. And all in all, time to recovery was 4 versus 6 days. So it was very positive. So then we were very optimistic and immediately cracked on with lap Whipple. So for laparoscopic Whipple, we had a different trainer from Belgium that time. 114 cases in 4 hospitals, including number very 1 from all the hospitals. The centers did 19 Whipples per year. This is probably where we went wrong, because this is not a lot. And conversion rate was low in the beginning. Fistula rate is high. But these patients are selected to have no vascular involvement, a soft pancreas. And the 90-day mortality, actually pretty good, taking into account that these were the very, very first cases. So immediately thereafter, we did a randomized trial. And if you randomize 1-to-1, this volume will go down to only 10 per year. So this trial is published in Lancet Gastroenterology. And the Data Safety Monitoring Board told us you need to shut down the trial. After we randomized 100 patients, mortality was 10% in lab, and it was 0% in open. So it could still be by chance, but we weren't taking any risks. And time to recovery was not better. So we shut down the trial. We had a meeting. And as a country, we said, we're going to abandon this technique altogether. We're going to stop doing lap Whipples. But we were happy to have an alternative, which is robot Whipple. Same could have happened, of course, but we said, what we'll do, we'll bring in our American friends. So Melissa Hoag, Amer, and Herb, who's now in Chicago, still in Pittsburgh and in Dallas, and ask them to train us. So they have a very good training program, very super detailed description, video training, simulated training, where you need to get all the exercises in a 95% level before you move to the next step, which is then biotissue training, proctoring offsite, and then they came to the Netherlands for full weeks, and my Ph.D. drove them around the Netherlands, so they were doing proctoring robot Whipples across the country. There's really a huge effort on their behalf. And we agreed to now only train the centers that do at least 50 Whipples. So that's half of our number of centers, so only the high volume centers. I think this was a key decision. So you see Melissa in Amsterdam for one of their weeks. So we had a huge nationwide impact because of that. We trained all 8 high volume centers. And last month, we did robot Whipple number 1,000. And now in our country, 1 in 4 of every Whipple is being done robotically, and lapless went down to 0. You see Herb with me behind the console. So it's been an amazing success. Doesn't tell you anything about superiority. I'll show you some results. So this, I think, is the most important one. So for you in the audience who don't know about the 3 types of learning curve, I'll quickly run through them. So you have the feasibility, proficiency, and mastery. And you can think of it as like driving a car. So feasibility is like you put a child behind the car and is able to get the car out of the street. So you're feasible. Proficiency, you get your driver's license, and this is mastery, like 1 to 3 years after your license. You're at your best. So in the literature, for pancreas, this translates to operative time, complications, and textbook outcome. And clearly you have done this, or you can do this for all your procedures. So in the literature, the cutoffs are at 25, 100, and 240. And because of our training program, we got this down to 15, 62, and 84, because we got proper driving lessons. Of course, if you're the first one setting up a technique, you can't, but this tells you the huge impact of taking a structured approach. So then if we look at the first 698 propensity score matched cases, you see that in the beginning, we were not harming patients for morbidity, mortality. This is fistula, this is bleeding, bowel leak. So they're all the same. And in the beginning, just some small benefits from chyle leak, wound infection, and 1 day faster hospital stay. So I don't know whether these benefits will get bigger with time, but certainly in the beginning, we had no major problems. So very happy with that. But we are left with a problem. And the problem is that even though we trained the high volume centers, still some of them during or after training only did less than 20 robot Whipple. And we know very clear from the US data, if you do less than 20 robot Whipples, the mortality is higher than open. So you need to do it enough. So you need to be trained and do it frequently enough. So conversion in these low volume centers, almost twice as high. Mortality, more than doubled. Failure to rescue, so the chance of dying from a complication, more than 3 times higher. So all of these surgeons were trained, and then still there's a huge impact of your volume. So this is just one slide about our own centers results. So we've now done 195 robot Whipples. We do every Monday, if I'm in the country, so not today, but every Monday we do a robot Whipple. So we do 45 of our 160 Whipples per year with the robot. Our surgical console time, you can see this is the blue line is us. This is the rest of Europe. I don't know what happened here, but our console time has gone down now to 3.5 hours. We can do 2 in a day. Conversion rate 4.6, mortality 1.5, and the median admission time is 8 days, and a quarter of them go home until day 5. So we're pretty happy with those results, but clearly we need a randomized trial, and I'll show you later. I just, as a second example, want to show you this. I mean, how you can use a collaborative approach to implement a technique. You see Professor Del Chiaro, and sorry, ladies, that it's all four white men. That will change, but from Heidelberg, New York, from here, and from M.D. Anderson, helping us with surgery for locally advanced pancreatic cancer. So we set up this training program with webinars, off and on-site proctoring, and an expert panel. So every 2 weeks online, we discuss all patients that might end up having surgery for locally advanced pancreatic cancer. And this is a nationwide approach. We got the oncologists involved, the radiotherapists, all the surgeons. So you just see this is Marco's tweet when my coworker Joris Erdman came here. This was 2 weeks ago in New York. This was just, no, it was September, sorry. This was 2 weeks ago here in November at M.D. Anderson. And so far, we're actually ahead of schedule. We had planned to do 55 resections in a short period. We're actually up to 92. And the inclusion rate is going well. So we're very happy with the results. I don't have the final outcome, but I can tell you that we had 0 in hospital mortality thus far. And then you have friends. So you end up writing great papers. This is Nature Reviews last week with the same group of friends. All right, so that works in the Netherlands, but what about Europe? So same thing. So this is the diploma trial. Basically, we copied the trial we did before, but now only for patients with pancreatic cancer. It's published in Lancet Regional Health Europe. And the same thing. So although it does take more time, you see here 2015, 16, 17, 18, and then only the first randomization. So it takes years to talk with your friends of all these countries, talk about surgical techniques and details, but it's worth it in the end. Because even because of COVID was here, right? So even throughout COVID, we managed to get a good accrual rate. So even this even works as approach in Europe. So then we said, okay, now we can do robot ripples in the Netherlands. So now let's train our friends in Europe. So we copied the exact same thing as Melissa did with us. So we are now training all the centers in Europe who are interested and do at least 50 Whipples per year, completely free of cost. The only thing we ask from them in return that thereafter they put all the patients in our quality registry, which then produces research again. And we've trained now 20 of the largest volume centers across Europe, some of which you see here. And then the nice thing that comes from that is that every Monday we have the OR is bigger now. Now I would say it used to be packed, but now they're in the corner. But we have a lot of friends visiting us to do the robot ripple. And then once they are ready, and only the high volume ones and who went through the rest of the curriculum, then we go there and we help them with their first robot ripple. But when we go there, they do the surgery. We are not doing the surgery. So it's actually been a very, very good experience. So then back to the randomized trial. I mean, of course, you can do the procedure, but you actually need to show it's worth the money because, of course, a robot is expensive. So this is the Diploma 2 trial. Again, patients were blinded. They were wearing a Fitbit watch for the first 3 months. You see all the centers here that joined. We had to say goodbye to our friends in Moscow after they started the war, but still we had a sufficient number of centers left. And actually this trial included at some point 25 patients per month here. So we finished 3 months ahead of schedule with the Diploma 2 trial. So we're working on the results. We have the final education meeting actually the day I come back. So what we're going to do, we're going to take the patients with pancreatic cancer and distal cholangiocarcinoma from the first trial, add 270 more. So we have 396 for the Diploma 2x2 trial. So this is the rollover design. So basically you don't have to do it all over again. You can continue your trial to also answer the question for radicality and survival for robotic ripple. Initially it was also laparoscopic ripple, but now basically everyone in Europe stopped doing that. So now this trial is going to be purely robotic. So again, a slide with some lessons that we learned. So this was also feasible in Europe. It requires big understanding of local practice, which varies hugely across Europe between countries. And of course, very good communication. We're very lucky to have this system with Ph.D. students who are full-time available and who basically do all of the work. So at my hospital, we have 90 Ph.D. students for all of GI. So that's cancer, that's general surgery, that is oncology, pathology, gastroenterology. And we have only 2 staff supporting them. Actually 1.5 FTE. So all the work is being done by the PhD students. So you need to look at practice variation and you need to be very clear. And this is a key point. In all the protocols, we have a big paragraph on all the details of who's going to be the 26th, the 27th, the 74th author exactly, all agreed upfront. So there can be no debate in the end. So and then finally, why stop at Europe? We're also doing this globally. We made this team called GAPA Search, Global Audits on Pancreatic Surgery, wherein we combine and compare the data from NSQIP, Sweden, Germany, and the Netherlands. And we have already found some enormous differences. For instance, Whipple surgery in the US, 75% of patients is ASA 3, whereas in Sweden, it's 3%. So there must be something going on with the coding, and this has led to a follow-up project, and we are talking to ASA now of giving some updates on the classification because you cannot compare the literature. Everybody is coding these patients, strangely enough, in a different way. So in the end, it all comes down to this. Basically, if you want to go fast, go alone. If you want to go far, go together. So a few pitfalls. So the single center trial, we've seen this. Typical example is trials from Memorial Sloan. For instance, there's a pancreas trial from Memorial Sloan that you need to use Paciriotride to prevent fistula after pancreatic surgery. It's in the New England, it works. No one in the world is doing it. Because they're saying, yeah, Memorial Sloan patients, probably going to be different for us. The drug is expensive, we're not going to do it. So actually the single center trial is, I think, a big pitfall. The one man or the one woman show. So I am up here now, but it could have been 3 or 4 other guys and girls from our group. Industry taking control. So we have had trials where industry wanted to give us 5 million euro. And then they said, listen, the control group needs to be this drug of ours, and the intervention needs to be this drug of ours with the thing you're interested in. And we were like, no, we don't use this drug you want in the control group. We don't want your money because the control group is not general practice. So the trial would be pointless. So you need to be very careful of that. And then another typical thing that happens is that people make the trial too complex. They go on doing 6 blood measurements per day. We need to go into freezers and stuff. You need to keep it very, very, very simple. This I said already, control arm should become a practice. People who fail to put detailed paragraph and authorship issues in the protocol is a very common mistake. And then, of course, this is we all suffer with this, also in the US, I know, the costs and the regulations. So some pearls. So I think you got by now that the collaborative approach can be very successful. Start with friends. Number 2, be very pragmatic. PhD students are probably here, residents, and then run pragmatic trials with questions from everyday practice. Then also your negative trial can be highly relevant. Authorship rules. For the sake of time, I can't go into this, but for instance, if you have an ongoing registry, you can do something called a registry-based trial. So you randomize the patients for something very simple like should you type A or B or drain or no drain, something very pragmatic, and then you do nothing else. Then all the outcomes will come from your ongoing registry. This is a little bit philosophical probably, but try to give a bit more than you take. It's probably the same for all of life and all of collaboration. And what we also did in the past, if we had big internal issues, for instance, about epidural with anesthesia or low fluid in liver surgery, you can argue for a decade or can just do one randomized trial. And in our case, we ended up 1-1. So first trial surgery 1 and the second one anesthesiology, and everyone's happy and all the debate is over. So in conclusion, surgical research is improving, no doubt about that. I showed you the systematic review. If you do pragmatic trials, also the negative trial becomes relevant. Nationwide or multi-center, or here probably state or multi-state study groups can be highly effective. We can do this internationally as well. And there are very specific pitfalls and pearls available, but basically it all starts with friends. Thank you very much.
I think we can open for questions.
Rich.
Marc, thank you so much for coming and delivering this talk. And I know you've done it under duress with all the things going on at home. So thank you again. You know, what you've done is simply impressive, and your ability to organize, you know, surgeons and other physicians is incredible. And I think there are many, many lessons to be learned. And, you know, I want to emphasize your point that I think in your situation, the negative trials were as important as the positive trials because it puts to rest a lot of the debate, and, you know, maybe it allows the use of less expensive alternatives. And so I think it adds almost as much information as your positive trials. So my question is, you are in a unique situation where you could, you know, maybe for a little bit more effort, collect specimens, cancer tissue, normal tissue, blood specimen, bile, you know, whatever. And, you know, and you've probably done some of this already, but you could turn this network into not only a discovery apparatus for what's the best technique, but how to get us to the next biologic cure with genomics, metabolomics, and proteomics. And I'd be interested in your thoughts on that.
Thank you very much. Yeah, for instance, for the PREOPANC 2 and now the PREOPANC 3 trial, we did that. So we had meetings and we said basically who wants what, and we added it all up. But first thing we started the trial. Because what I see a lot is that people want to do it all at once. So they want to have the clinical trial and set up the infrastructure for tissue and blood at the same time. And then people become frustrated and don't do it because it's just too much. So I think lesson one is get the trial going, and then once that's sort of through or with ethics, whatever, then set up the second part. We did it only for interested centers. Those should, of course, at least be the ones who want something back. And I think on the back of PrePank 2, we're doing like 6 to 8 preclinical studies at the moment. But I must emphasize that it's a lot more difficult. So I was also involved in setting up a nationwide pancreas biobank. The problem there is that you have, and you know this, but you have the biobank, but you don't have the clinical data. So actually, I think, as you said, that we should invest much more in doing biobanking on the back of a trial, rather, because we have a huge biobank. I think we are like 8,000 patients in it, and only 2 studies came out of it. Because whenever you say, okay, I want females between 30 and 50 with pancreatic cancer, and no one can find them. So I think exactly as you say, you should do biobanking, preclinical work, back to back during the trial. So you also have all the clinical data.
Other question? Yeah, Robert.
Question I have is, can you distill a few points for the residents and trainees in the room who could take this as they move into their clinical practices?
Yeah. So typically what you see a lot, and of course the US situation is different from the Netherlands, but typically what I see from outside looking to the US, you go to a meeting and there are like 12 papers from 12 centers who all did the same SEER or NCB analysis. And it's nice, but basically it's 12 the same papers, and everyone spent a lot of work into it. So if you create one group, say with residents from 10 sites, work with your chief or get approval, you could do it with or without, but you need to get approval. But then the group could think of the topics. One could have done that SEER analysis, and all the others would be on that paper. Now, if you have online meetings and everyone thinks on the topic and you have a discussion on the analysis and they read the final manuscript, that actually fulfills the official authorship criteria. Then the next one does the next paper. Then all of a sudden, you have 10 papers for the price of 1. Of course, you had a few evenings on Zoom, right? But you multiply. I mean, I didn't do all these trials myself, of course. So you multiply by that. And then again, you never showed, I'm not sure if it's allowed in the US, but you would never show the Anschutz logo. You would show the Midwest Pancreas Resident Collaborative Study Group logo, and that's it. So it's a multiplier, but I know it takes effort. And of course, I come from this tiny bubble on Earth where this is possible, but there is basically no reason why it shouldn't work here.
Hi, a brilliant talk. Thank you for visiting us, and very intriguing and a phenomenal body of work. I'm just interested if you can give us some thoughts on trial design, right? We are all fraught with lots of negative trials, and I agree with Dr. Schulich. We get a lot of insight and information from them, but oftentimes it's because the trial design was too narrow. And in this era of personalized medicine, where a patient may or may not fit into that treatment regimen, maybe the answer is in big data. Maybe the answer, like Dr. Schulich suggests, is in biobanking or big data sets. And I'm wondering what your thoughts are and what the consortium thoughts are, because in the era of precision medicine, maybe bigger data and less trials where we have just 2 arms or even an adaptive design might be the way to get insight, especially since that's how we practice medicine, right? Each patient is a little bit different than the one before.
Yeah. 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 So you hear that a lot, but then how many trials have you or have I seen where actually such a design has shown a better outcome? So I think 2 things happen. I think one, in general, people are too eager to get their own trial, right? So they do the sample size SAMBA, they calculate down to the minimum number of patients needed so they can get it done in their own center in 8 years. And then you get a trial with an in the end, that doesn't really answer anything. So that's one. And the second thing is that if you design the trial in-house, you don't have enough critical people. Probably there's a strong leader, everyone listens to the leader, and there's no contra argument. So what I find a lot in this group, it takes forever before we agree on a trial design. But that then essentially was the peer review process, right? And then typically you need a bigger trial, than you would have done yourself. And then finally, for the comment about sort of personalized medicine approach, what you could do is this goes for any type of surgery, you probably can think of 1 or 2 or 3 or 4 subgroups, and you can look at these subgroups and randomize these patients between either personalized approach, meaning you have 4 or 5 treatments, versus current standard practice. So that could be done, and we're trying to do that in something that's called a cohort multiple trial. So we run a prospective cohort. Everyone that comes through the door signs the consent, and in that cohort, 10 trials are ongoing. So the patients who fit a profile, they get a phone call. Do you want to be in this trial? Because we got this great new drug for you. And then the interesting thing is that the control group do not know they are in a trial. So it's also called TWICS, TWICS, trial within cohorts. So in that way, you can set up one sort of machinery and you can run multiple small trials for small subgroups. So that's the other option, trials within cohorts.
I think, Max, I see you have the microphone. Yeah.
Really excellent presentation. What are finding ways for collaboration between the US and your groups in Europe? What are some opportunities there and maybe some barriers?
Yeah, thanks. Well, I think it's very well feasible between Europe and the US. I think for starters, I think there's more research funding in the US than in Europe. We have really struggled to get funding. We did the diploma trial I showed, the one that was published in Lancet Regional Health Europe. There were some 3 US sites involved. The only thing they thought they couldn't do was blind the patients. They thought the US patient would be too much for the US patient. I don't know how it works, but anyway, they joined. We have now a current ongoing collaboration called TROPANC, so Transatlantic Robotic Pancreatic Consortium, where we just merge data. Because the problem is in Europe, a lot of us do exactly the same things. For instance, in the Netherlands, practice variation very little. So you can get very interesting results by comparing with the US, where you have more practice variation. For instance, at the moment, we're comparing the Texas Cancer Database with the Netherlands, where we have the full denominator. And very interesting things pop up from that. So yeah, I'd like to. Yeah, it's possible.
Martin?
Yeah, that was very inspirational about what can be done with surgical trials. And along those lines, I'd like you to comment a little bit more about how you go about obtaining funding to run a surgical technique trial. That's something we often have trouble doing. And 2, how the Netherlands set it up such that you have so many PhD students interested in clinical trials?
Yeah. So to be honest, they are not. They just want to become a surgeon, right? So the best ticket to get into, so for surgery training, for every single position in surgical residency in the training program, there are 25 to 35 applicants. So if you don't have a great PhD, well, 1 or 2 may get a position, but it's very difficult. So that's 1. 2 is, of course, it's a great period because you get to travel the world and do good research. So they're not inherently different from anyone in a different else in the world. The funding is a problem, but having said that, for instance, we just finished a trial, very simple trial together with Italy and 14 Dutch centers, drain or no drain in distal pancreatectomy. Simplest trial ever. Basically done without funding. We had money for a PhD who runs the European Registry for minimally invasive pancreas surgery. We got Ethicon to give everyone the same stapler for all the patients. So we could say the entire trial, half of them already had Ethicon, the other half got an Ethicon stapler, so all the patients the same stapler. And that's it. And for monitoring, the hospital has a system with 3 levels, high to low risk. Low risk monitoring is like €5,000 for an entire multi-center trial. High risk is €30,000 and ethics is €2,000. So we can still do trials at low cost. For instance, the pre-OPEC neoadjuvant chemotherapy trials, they were done on a budget of €500,000. Here would be at least 10 times as much. But still, we struggle to get funding, especially since the PhD salary went up. So before taxes, we pay 85,000 basically euro per year for 1 PhD. So that's now our biggest struggle to maintain that level of activity.
Ben?
Congratulations. I have a question on your robotic program. It's wonderful. You created it and you got some great proficiency in a very short amount of time. When you're comparing those data of robotic pancreas with open pancreas, I imagine I might be wrong, but a lot of people that start doing robotic pancreas when they start the program start with, soft pancreases, cholangiocarcinomas and ampullaries. And so actually, those are the patients that will leak more. So it's even more impressive when you compare them to the open cohort, which are patients with hard pancreases and large duct, that actually they stuck up well. Was that the case for you?
Yeah, so the results I showed, where there was no difference in leak rate, were matched. And there are now 5 randomized trials, lab versus open Whipple. All the leak rate is the same. But your point is very important. So if we do a proctoring, usually in the morning we get given the opportunity to give a lecture like this, and I tell the audience, listen, and it's usually the surgical department, from now on, your open pancreases will no longer leak, right? And they start laughing, and then I explain this because from now on, all the easy cases will be done with the robot. So your leaks will shift from open to robot, and your open ones will only be the neoadjuvant treated PDACs. And in the beginning, at my center, no one told me that. I wish Herb or Melissa had told me that, because after a few months, vascular surgeons and the colorectal team, they were gossiping in the hallway. Look, Besselink's Whipples are all leaking. What's going on? All the robots are leaking, because you hear in the morning, you hear the stories about another leak. So that's a very important point. It's by design, because you select the ones that will leak.
Another question? I actually have a question for you. So I've been lucky enough to work with your PhD students, and I think really the level of expertise in methodology, in statistics is incredible from the very beginning. So is there a common pattern for PhD students in the Netherlands that go through in order to be so efficient and so well prepared to run even very complex studies?
Yeah. So there's a set pathway in all the universities. So when they come in, they have an onboarding, much like surgical residency, and they need to get X number of points per year in training, and they get all the courses, writing course, statistics course, anything you can think of. So I think it's crucial. And for the trials, we will send them off to Oxford, where you have this great 1-week course, purely clinical randomized trials.
Yeah. Any other question? Okay, before to close, I want to remind everyone there is a case discussion with Dr. Besselink. We start 8:30, 6th floor, academic office 1. So whoever of the trainee, resident, faculty that is available, please join. Marc, thank you really very much. Congratulations. And we hope to have you here soon again. And this is a small present for you, a small memory for University of Colorado. Inside there is several things, including our tie. Yeah. And again, thank you very much.
Thanks, guys.